will be the genitourinary system of Pance Prep Pearls, male and female. We'll start with different types of incontinence. First, urge incontinence. This is involuntary leakage of urine preceded by or accompanying a urge to urinate. This is most common in older women. And the pathophys is detrusor muscle overactivity. The detrusor muscle is stimulated by muscarinic acetylcholine receptors. Detrusor overactivity leads to uninhibited, involuntary detrusor muscle contractions during bladder filling. Etiologies are increased age, idiopathic and bladder infection like cystitis. Clinical manifestations of urge are increased urgency, frequency, small volume voids, and nocturia especially. The patient has a strong urge to void with the inability to make it to the bathroom in time, especially nocturia. For management, first line is bladder training, 75% improve with this. Timed frequent voiding, using a voiding diary to identify the shortest voiding intervals, and decreased fluid intake. For diet, they can avoid spicy foods, citrus fruit, chocolate, alcohol, and caffeine, also lifestyle modifications and Kegel exercises. For medical management, you can do anti-muscarinics, which are the first-line therapy, such as tolterodine or oxybutynin. The mechanism are anticholinergic and antispasmodic that also increase bladder capacity and inhibit the detrusor contraction. Mirabegron is a beta-3 agonist that causes bladder relaxation. Tricyclic antidepressants, TCAs, like imipramine can be used. Their mechanism for this is central and peripheral anticholinergic effect, and alpha-adrenergic agonist leads to bladder muscle relaxation, increased bladder outlet resistance, and an antispasmodic effect on the detrusor, and increased urethral sphincter tone by alpha-1 agonist. Surgical is last line, which increases bladder compliance with injections of Botox or bladder augmentation. Next, for overflow incontinence. This is urinary retention and incomplete bladder emptying, leading to an involuntary urine leakage once the bladder is full. It overflows. Pathophys is bladder detrusor muscle underactivity, impaired contractility, or bladder outlet obstruction. So it could be a neurocause due to the impaired contractility, or a bladder outlet obstruction that's like BPH, a stone, or a tumor. Etiologies of overflow, most common in neurological disorders or autonomic dysfunction, like diabetics, MS, spinal injuries, spinal stenosis, peripheral neuropathy associated with B12 deficiency as well, or lack of neuroinnervation of the detrusor. Also common with bladder outlet obstruction, such as with BPH, or uterine fibroids, or pelvic organ prolapse, or overcorrection of the urethra from prior pelvic floor surgery. Clinical manifestations of overflow will be a loss of urine with no warning, as in urge, or triggers, as in stress. Leakage or dribbling in the setting of an incomplete bladder emptying, weak or intermittent urinary stream, hesitancy, frequency, and nocturia. Leakage often occurs with changes in position. Diagnosis is a post-void residual over 200 milliliters. So urine is kept in the bladder. Management of bladder atony is intermittent or indwelling catheterization, first-line treatment. Cholinergics like bethanechol increases the detrusor muscle activity as well. Management of BPH, alpha blockers for rapid symptom relief, and 5-alpha reductase inhibitors like finasteride and dutasteride for more longer term. And those alpha blockers for rapid symptom relief in BPH are tamsulosin, prazosin, terazosin, and doxazosin. Stress incontinence will be next. Stress incontinence is an involuntary leakage of urine that occurs once increased abdominal pressure due to exertion, coughing, laughing, or sneezing that is greater than the urethral pressure and the resistance to urine flow. So the increased abdominal pressure is greater than the urethral pressure. Most common type of incontinence in younger women, especially 45 to 50 years old. Etiologies are laxity of the pelvic floor muscles due to childbirth, surgery, postmenopausal estrogen loss, although rare in men, post-prostatectomy may be associated with stress incontinence. Also, urethral hypermobility, insufficient support from the pelvic floor musculature and the vaginal connective tissue to the urethra and bladder neck. Clinical manifestations, urine leakage during times of increased intra-abdominal pressure, coughing, laughing, sneezing, lifting heavy objects. There is no urge to urinate prior to this leakage, importantly. For stress incontinence, the management, first line is pelvic floor Kegel exercises, which is the initial management of choice. Kegel supportive therapy includes supervised therapy, vaginal weighted cones or biofeedback, bladder training such as timed voiding, topical estrogen for postmenopausal women with vaginal atrophy as well. For stress incontinence, you can also do lifestyle modifications, which are used in conjunction with pelvic floor exercises, such as protective garments, pads, weight loss, smoking cessation, and drinking smaller amounts of water throughout the day. Pessaries can be used if incomplete efficacy with lifestyle and muscle strengthening or situational stress incontinence. And surgery is last line. This would be a mid-urethral sling. Higher success rates than conservative therapy. More rapid and definitive treatment with this surgery. That's the mid-urethral sling. Also, alpha agonists can be used, midodrine and pseudoephedrine, but they're only mildly efficacious. So they contract the urethral opening and increase the resistance, mediated by norepinephrine and the alpha-1. Next will be uterine prolapse, uterine herniation into the vagina. Risk factors: weakness of pelvic floor structures, most common after childbirth, especially traumatic. Increased pelvic floor pressure, multiple vaginal births, obesity, repeated heavy lifting, loss of estrogen postmenopausally. Clinical manifestations of uterine prolapse are vaginal fullness, heaviness or a falling out sensation, low back pain or abdominal pain. Symptoms may be worse with prolonged standing and relieved with lying down. Urinary urgency, frequency, or stress incontinence. For physical exam, a bulging mass, especially with increased intra-abdominal pressure, such as Valsalva. Grade 0 would be no descent to 4 through the hymen. So grade 0, no descent. Grade 1, uterus descends into the upper 2/3 of the vagina. Grade 2, the cervix approaches the introitus. Grade 3, the cervix is outside the introitus. Grade 4, the entire uterus is outside of the vagina, a complete rupture. This also may be accompanied by a cystocele, which is posterior bladder herniating into the anterior vagina. Also an enterocele, which is the pouch of Douglas, which is small bowel herniating into the upper vagina, or rectocele, which is distal sigmoid colon or rectum herniating into the posterior distal vagina. Management can be mechanical. Pessaries elevate and support the uterus. Estrogen treatment may improve atrophy. Also surgical for uterine prolapse. Hysterectomy or uterus-sparing techniques include uterosacral or sacrospinous ligament fixation. Next will be Peyronie's disease, an acquired localized fibrotic change of the tunica albuginea leading to an abnormal penile curvature. Pathophys is unknown, but contributing factors include penile trauma, tissue ischemia, and genetic susceptibility. This leads to excessive collagen, fibrous plaques forming. Clinical manifestations are penile pain, curvature, induration, shortening, and or sexual dysfunction. Management, observation, urology referral. Observation is an option for a mild curvature, 30 degrees or less, and medical or surgical management. If curvature is 30 degrees or more or associated with sexual dysfunction, you can also use oral pentoxifillin within 3 months of onset. Intralesional injections with collagenase Clostridium histolyticum if over 3 months. Next will be vesiculo-ureteral reflux. Retrograde passage of urine from the bladder into the upper urinary tract. Types of vesicular-ureteral reflux are a primary VUR, which is the most common type, due to inadequate closure or incompetent ureterovesicular junction, UVJ, that contains a segment of the ureter within the bladder wall. Low-grade reflux, grades 1 and 2. Secondary VUR, this is due to abnormally high voiding pressure in the bladder that leads to failure of the closure of the UVJ during bladder contraction. So increase in the pressure and it can't close, so the urine backs up. Clinical manifestations: prenatal presentation, you may see hydronephrosis on prenatal ultrasound, and postnatal, they might have a febrile and a UTI. Diagnosis of VUR. Renal and bladder ultrasound is often the initial imaging ordered, but it also may miss significant VUR. Voiding cystourethrogram imaging is the test of choice for VUR, or radionuclide cystogram. So ultrasound and then cystourethrogram. An initial postnatal renal ultrasound is performed in all patients with prenatal hydronephrosis. A voiding cystourethrogram is performed in infants with persistent postnatal abnormal ultrasound findings or who develop a UTI. For management of grades 1 and 2, you may observe first or antibiotic prophylaxis to reduce the risk of recurrent UTIs, such as Bactrim or nitrofurantoin. Grades 3 and 4, surgical correction is the definitive management. Next will be acute cystitis. So pathophysiology, usually an ascending infection of the lower UTI from the urethra. Risk factors, women, sexual intercourse, honeymoon cystitis, spermicidal use, especially with a diaphragm. Pregnancy, progesterone estrogen causes ureter dilation and inhibition of bladder peristalsis. Elderly and postmenopausal, diabetics in the presence of an indwelling catheter. In children may indicate vesiculo-urethral reflux as well. Infants should receive a bladder and renal ultrasound to rule out congenital abnormalities. If it's a complicated acute cystitis, underlying condition with a risk of therapeutic failure, so symptoms over 7 days, if they're pregnant, it's automatically complicated, diabetics, immunosuppressed, indwelling catheter, anatomic abnormalities, elderly, and also males. Etiologies are E. coli, most common, over 80%, and don't forget Staphylococcus saprophyticus, which is the second most common in sexually active women. Other gram-negative uropathogens, Klebsiella, Proteus, Enterobacter, and Pseudomonas. Enterocoli in indwelling catheters. Clinical manifestations, irritative symptoms like dysuria, frequency and urgency. That's FUD, frequency, urgency, dysuria. Hematuria, suprapubic pain, and tenderness may also occur. And don't forget to look out for back pain and CVA tenderness. Diagnosis on urinalysis, pyuria, over 10 white blood cells per high-powered field. Hematuria, leukocyte esterase, nitrites, cloudy urine, bacteriuria, and increased pH with Proteus, which remember predisposes for those staghorn nephrolithiasis. Urine culture is the definitive diagnosis. Women over 1,000 CFU per milliliter of uropathogens, clean catch specimen. Epithelial squamous cells equals contamination. Indications for urine culture, a complicated UTI, in infant or children, elderly, males, urologic abnormalities, refractory to treatment, or catheterized patients. If for management of an uncomplicated acute cystitis, first line is nitrofurantoin or Bactrim, trimethoprim, sulfamethoxazole, or fosfomycin if resistance pattern is under 20%. Second line is a fluoroquinolone, maybe used first line in sulfur allergies or increased resistance patterns. Cephalosporins or cefpodoxime can be used too. Adjunctive treatment, increased fluid intake, void after intercourse. Hot sitz baths may provide relief of abdominal discomfort. Phenazopyridine is a bladder analgesic, azo, pyridium, not used more than 48 hours due to the side effects, hemolytic anemia. Inform the patient phenoperazidine pyridium turns the urine an orange color and may also show up in the complete urinalysis. Complicated, fluoroquinolones, PO or IV, also aminoglycosides can be used depending on the severity. Cystitis during pregnancy, you want to use amoxicillin, augmentin, cephalexin, cefpodoxime, nitrofurantoin can be used, and fosfomycin can be used. Avoid Bactrim, trimethoprim, sulfamethoxazole in the first trimester. Also avoid aminoglycosides, fluoroquinolones, and doxy. For asymptomatic bacteriuria, asymptomatic patients with incidental bacteriuria on urinalysis. No treatment is needed. For the general population, elderly, diabetics, non-pregnant, premenopausal women, spinal cord injury patients, or patients with chronic indwelling urinary catheters. No treatment is needed for asymptomatic bacteria. Treatment is needed in pregnant patients and patients with urologic intervention and hip arthroplasty. Pregnancy requires screening and treatment because it can be associated with preterm birth, perinatal death, and pyelo in the mother. So very important, treatment needed for asymptomatic bacteria in pregnant patients with urologic intervention and hip arthroplasty. Next will be pyelonephritis. This is an infection of the upper genitourinary tract, the kidney parenchyma, and the renal pelvis. Pathophys is an ascending infection from the lower urinary tract. The etiologies are again E. coli most common, over 80%, and you can remember the organisms as PEKEP, P-E-K-E-P. So that's Proteus, Enterococci, Klebsiella, E. coli, and Pseudomonas. Risk factors: diabetes mellitus, history of recurrent UTIs or kidney stones, pregnancy, congenital UTIs, or congenital urinary tract malformations. Clinical manifestations: upper tract symptoms, fever, chills, back or flank pain, nausea and vomiting, not common but suggestive. Lower tract symptoms: dysuria, urgency and frequency. Physical examination: positive CVA tenderness, fever, and tachycardia, importantly. Positive CVA tenderness. And remember, you may have that high spiking fever. For diagnosis of pyelo, on urinalysis there'll be pyuria that are over 10 white blood cells per high-powered field, positive leukocyte esterase, positive nitrites, 90% bacteria causing UTIs would have positive nitrites, hematuria, cloudy urine, and bacteriuria. White blood cell casts are hallmark for pyelo, so that's very important. White blood cell casts are hallmark for pyelo. Also an increased pH with Proteus. Again, the staghorn, struvite, alkalotic crystals. Leukocytosis with a left shift on CBC, and you need to do a urine culture, which is the definitive diagnosis. So management is either outpatient or inpatient. If you're doing outpatient, you want to do a fluoroquinolone first line. If resistance, initiate IV ceftriaxone or Gent, followed by an oral fluoroquinolone. For inpatient management, you can do a third or fourth generation cephalosporin, fluoroquinolones, aminoglycosides, or extended spectrum penicillins for a total duration of 2 weeks. Indications for admission include older age, signs of obstruction, comorbid conditions, or inability to tolerate oral antibiotics. If they're pregnant, IV ceftriaxone is first line, as Trionam if penicillin allergic. Avoid Bactrim, aminoglycosides, fluoroquinolones, or tetracyclines like Doxy. Next will be urethritis. So first, non-gonococcal urethritis, NGU. Chlamydia is the most common cause of non-gonococcal urethritis. Chlamydia is also the most common bacterial STI in the US. 5 to 8 days incubation period followed by a purulent or mucopurulent discharge. May be associated with pruritus, hematuria, or dyspareunia. Up to 40% are asymptomatic, however. Others include ureaplasma urolyticum, trichomonas, mycoplasma genitalium, and viruses. And there's also gonococcal urethritis, which is an abrupt onset of symptoms, especially within 3 to 4 days. They may have an opaque, yellow, white, or clear, thick discharge and itching. Up to 20% are asymptomatic, however. For urethritis, urethral discharge and penile or vaginal itchiness, dysuria seen in both gonococcal and non-gonococcal urethritis, abdominal pain or abnormal vaginal bleeding. For diagnosis, that's your NAAT, the nucleic acid amplification test, which is most sensitive and specific for chlamydia, gonorrhea, and mycoplasma genitalium, which is recommended over culture. And you want to do a first void or first catch urine, which is ideal. For gram stain, 2 or more white blood cells per high-powered field, and no organisms seen suggestive of NGU. Gram-negative diplococci equals Neisseria gonorrhea, importantly, and a urethral swab. Urinalysis or dipstick, positive leukocyte esterase or dipstick of 10 or more white blood cells per high-powered field, which is pyuria, on microscopic, which is suggestive of urethritis. Management, 25 to 30% of patients have a co-infection of both gonorrhea and chlamydia, so empiric treatment of both is recommended if the test results are not available. So very important. You want to give for Neisseria gonorrhea ceftriaxone 250 milligrams IM once plus azithromycin 1 gram plus 1 dose for additional coverage of gonorrhea due to increased resistance as well as to possibly cover for chlamydia. And for here, chlamydia is azithromycin 1 gram orally, single dose that's observed, or doxy 100 milligrams orally 2 times a day for 10 days. So this is in Pance Prep Pearls. However, in practice, you now do the ceftriaxone 250 IM, not plus azithromycin, but you just add doxy instead. So it's just ceftriaxone plus doxy. Doxy is still orally 100 milligrams BID for 10 days, and the ceftriaxone intramuscular shot. Next will be prostatitis. Prostate gland inflammation secondary to ascending infection. The etiologies of acute prostatitis are, depending on age, if they're over 35 years old, you want to think of E. coli as the most common, as well as sometimes other gram-negatives like Proteus, Enterobacteriaceae, Klebsiella, Enterobacter, Serratia, and Pseudomonas. If they're under 35, you want to think chlamydia and gonorrhea. For children, if it's viral, you want to think mumps is the most common cause. So that's acute prostatitis. For chronic prostatitis, E. coli is the most common, over 80%. Also think of Proteus and those other organisms as well. Also consider a structural or functional abnormality in recurrent UTIs. Acute prostatitis may progress to chronic if over 3 months. In clinical manifestations will be irritative voiding symptoms like frequency, urgency, dysuria, obstructive symptoms like hesitancy, poor or interrupted stream, straining to void, and incomplete emptying, malaise, and arthralgias. For acute, you'll have fever, chills, perennial pain, low back or abdominal pain. For chronic, usually presents as recurrent UTIs or intermittent dysfunction. Malaise, arthralgias, symptoms are milder, and fever is not common in chronic. On physical exam, very important, the boggy prostate, which equals prostatitis. Acute prostatitis, they'll have an exquisitely tender, normal or hot, boggy prostate. So acute, exquisitely tender, boggy prostate. Chronic will be non-tender, but it's still boggy. They are sensitized to the pain already, so chronic will not be painful. Diagnosis, urinalysis and urine culture, pyuria and bacteriuria. In acute prostatitis, urinalysis and culture is often negative in chronic, so prostatic massage is often done in chronic to increase bacterial yield on urinalysis and culture. However, avoid prostatic massage in acute prostatitis, as it may cause bacteremia. Very important. Avoid the prostate massage in acute, but you can do it in chronic to get the bacterial yield. Transrectal ultrasound or CT of the pelvis with IV contrast may be helpful for suspected prostatic abscess. For management, acute and over 35 years old, fluoroquinolones or Bactrim for 4 to 6 weeks, so a little bit longer, and that's outpatient. If they are hospitalized, you want to use IV fluoroquinolones with or without aminoglycoside or ampicillin with or without Gent. Acute under 35 years old or an STI is likely. Cover for gonorrhea and chlamydia, again, ceftriaxone plus doxy, chronic fluoroquinolone or trimethoprim, sulfamethoxazole, Bactrim for 6 to 12 weeks, so a longer duration. Alpha blockers, tamsulosin can help with the chronic pain. Refractory chronic, TURP procedure, transurethral resection of the prostate. So for exam tip here, it has acute prostatitis, which is exquisitely tender, boggy prostate. And chronic prostatitis, usually non-tender, boggy prostate. BPH, symmetrically enlarged, firm, non-tender. And prostate cancer, rock-hard prostate. Next will be epididymitis. This will be epididymal pain and swelling thought to be secondary to retrograde infection or reflux of urine. A bacterial infection is the most common cause. For etiologies, males from 15 to 35 years old will be chlamydia, which is most common, and Neisseria gonorrhea. Also, don't forget E. coli, treponema, trichomonas, and Gardnerella are all possible but chlamydia and gonorrhea in under 35 again. Men over 35, enteric organisms. E. coli is the most common. Again, Klebsiella, Pseudomonas, Proteus. And if it's pre-pubertal, think about viruses as well as E. coli and Mycoplasma pneumoniae, and atypical. Clinical manifestations are gradual onset, epididymitis, over a few hours to days, and localized testicular pain and swelling, usually unilateral, groin, flank, or abdominal pain. May be associated with fever, chills, or irritative symptoms like FUD, frequency, urgency, dysuria. On physical exam, scrotal swelling and tenderness, epididymal tenderness and induration, posterior and superior to the testicle. The affected testicle is usually normal in the vertical position. You also want to look for the friend sign and cremasteric reflex for epididymitis. They'll have a positive friend sign, so they'll have some relief with the pain with scrotal elevation. This is classic but not reliable. They should also have a positive or normal cremasteric reflex, which is elevation of the testicle after stroking the inner thigh, which would be negative in testicular torsion. For diagnosis, scrotal ultrasound is the best initial test. You'll see an enlarged epididymis, increased testicular blood flow. So you always want to have that high suspicion of testicular torsion. So an ultrasound is the best to also rule out testicular torsion. Urinalysis for epididymitis, you might have pyuria or bacteria, and you want to do nucleic acid amplification when suspecting gonorrhea or chlamydia, once again under 35 years old. For management, scrotal elevation, NSAIDs, cool compresses. If they're under 35 or STI is likely, cover chlamydia and gonorrhea, again, doxy, 100 milligrams 2 times a day for 10 days, plus ceftriaxone, a 250 milligram IM shot once. And azithromycin is an alternative to doxy. If they're over 35 years old, cover enteric organisms like E. coli, cover them with fluoroquinolones. You can also use Cipro, ofloxacin, or levofloxacin. And Bactrim is also an alternative. Bacterial in children, cephalexin or amoxicillin. Next will be orchitis. Orchitis is caused by viral as the most common etiology, mumps especially, which is very high yield, echovirus, Coxsackie virus, and rubella. Clinical manifestations, scrotal pain, swelling, and tenderness. Physical exam, scrotal erythema and tenderness. Symptomatic management is the first line, because it is, after all, viral. So bed rest, NSAIDs, scrotal support, and cool packs. So it's basically the testicle itself is inflamed in orchitis, whereas epididymitis, it's the epididymis on the back posterior side of the testicle. So again, for orchitis is mumps, and also note that in mumps you have parotitis as well of the parotid gland. So next will be testicular torsion. This is spermatic cord twists and cuts off testicular blood flow due to congenital malformation. So it's most common in males 10 to 20 years of age and neonates that are at the highest risk. This is a true urologic emergency. Pathophysiology, insufficient fixation of the lower pole of the testes to the tunica vaginalis, the bell clapper deformity, importantly, leading to increased mobility of the testicle. Clinical manifestations, abrupt onset of scrotal, inguinal, or lower abdominal pain, usually under 6 hours. If nausea or vomiting is present, suspect torsion, as it's usually absent in epididymitis. And also note that epididymitis is more gradual as well, where this is very acute and abrupt. Physical examination, swollen, tender, retracted testicle, high riding, that may have a horizontal lie, which would be the bell clapper deformity. They'll have a negative friend sign with no pain relief with scrotal elevation, and a negative or absent cremasteric reflex of the affected side, so no elevation of the testicle after stroking the inner thigh, whereas epididymitis, it will be positive for both. For diagnosis, it'll be a clinical diagnosis. In a patient with a history and physical examination suggestive of torsion, imaging studies should not be performed. Rather, these individuals should undergo immediate surgical exploration. So, diagnosis, emergent surgical exploration, which is the definitive diagnosis, which is preferred over ultrasound if torsion is very likely. You can also do the testicular Doppler ultrasound, which is most commonly imaging used for this. You'll see a decreased or absent testicular blood flow. So if it's really obvious that they have it, you can do the emergent surgical exploration, or you can do the ultrasound as well. Management: urgent detorsion and orchipexy, ideally within the first 6 hours of pain onset. Irreversible damage likely after 12 hours of ischemia. Manual detorsion should be performed if surgical intervention is not immediately available. So you can do surgical detorsion or manual. Orchiectomy if it's not salvageable. And next, torsion of the appendix testes. Most cases are seen in children 7 to 14 years old. Clinical manifestations are an abrupt testicular pain, usually more gradual, however, compared to testicular torsion. On physical exam, there'll be a torsed appendage and a classic blue dot sign, a bluish discoloration in the scrotal area directly over the torsed appendage. Infarction and necrosis it represents. May be associated with a reactive hydrocele, fluid around the testes. So don't forget, torsion of the appendix testes is the blue dot sign. Diagnosis, primarily clinical, color Doppler ultrasound, low echogenicity of the torsed appendage with a central hypoechogenic area. Management: local application of ice and NSAIDs, and surgical excision of the appendix testes is usually only performed with persistent pain after initial management. Next will be cryptorchidism. This is a testicle that has not descended into the scrotum by 4 months of age. Most descend spontaneously, about 70%, and they're most common on the right side, 10% are bilateral. Most commonly found just outside the external ring, suprascrotal, inguinal canal, or in the abdomen. So most common is just outside the suprascrotal ring. Increased risk of if they're premature, 30% of premature versus 5% of full-term infants, and low birth weight. Also maternal obesity or diabetes. For clinical manifestations, there'll be an empty, small, poorly rugated scrotum. May have inguinal fullness if located in the inguinal canal. Diagnosis: physical examination in the majority of cases, scrotal ultrasound and MRI. For management, orchiopexy is recommended as early as 4 to 6 months of age for congenitally undescended testes, and definitively should be done before 2 years of age, ideally before 1 year of age, however. Orchipexy is testicular fixation in the scrotum so that it cannot retract. Observation can be done if only under 6 months of age. Most descend by 3 months of age, rarely spontaneously descend after 4 to 6 months of age. Very important. You can also get an HCG or gonadotropin releasing hormone. Human chorionic gonadotropin stimulates testosterone and hormonal testicular dissension. Rarely used, however, may be used in cryptorchidism associated with Prader-Willi syndrome. Orchiectomy is recommended if detected at puberty to reduce testicular cancer risk. Complications, very important, increased risk of testicular cancer, reduced as with an early orchiopexy. Decreased fertility, testicular torsion, and inguinal hernia. So very important, no increased testicular cancer risk if they do have a cryptorchidism. Next will be testicular cancer. Most common solid tumor in young men, age 15 to 35, with the average age of 32. Risk factors: cryptorchidism is the most significant, with a 4 to 10 times risk in both undescended and normal testes. Caucasians, Klinefelter syndrome, and hypospadias. Major types: germinal cell tumors are the most common at 95%. Non-seminomas are 2/3, and seminomas are 1/3. For non-seminomas, embryonal cell carcinoma, teratoma, yolk sac, or younger, choriocarcinoma, which has the worst prognosis, or mixed tumors, seminomatous plus non-seminomatous components. Mixed tumors are treated like non-seminomas. Non-seminomas are associated with an increased serum AFP, alpha-fetoprotein, and beta-HCG, and resistance to radiation. So non-seminomas, resistance to radiation, AFP, and beta-HCG. So longer word, non-seminomas to seminomas, and it has more stuff involved: AFP, beta-HCG, resistance to radiation. Seminomas have 4 S's. Seminomas are simple, as they lack tumor markers like AFP. They're sensitive to radiation, unlike non-seminomas, and they're slower growing and associated with a stepwise spread. Simple, sensitive, stepwise, and slower. There can also be, so that's non-seminomas and seminomas, which are under germinal cell tumors, which are most common. Those two comprise 95%, with the non-seminomas 2/3, seminomas 1/3. There can also be, at 3%, the non-germinal cell tumors, with the Leydig cell tumor, which may be benign. They may secrete hormones like androgens or estrogens, which may lead to precocious puberty in children, or gynecomastia and loss of libido in adults. Sertoli cell tumors are often benign, may secrete hormones like estrogens and androgens. There's also testicular lymphoma. So clinical manifestations: a testicular mass is most common, and it's usually painless. May have a dull pain or testicular heaviness, acute pain in only 10%. Secondary hydrocele present in 10%, and gynecomastia is rare. Physical exam: firm, hard, fixed mass that does not transilluminate. For diagnosis of testicular cancer, scrotal ultrasound is the best initial test of choice. Seminomas are hypoechoic, and non-seminomas are cystic, non-homogeneous mass. Tumor markers: increased AFP in non-seminomas, increased beta-HCG in non-seminomas, and again, remember, resistant to radiation, and especially choriocarcinoma as well for beta-HCG. Staging: CT of the abdomen, pelvis, and chest. For management of low-grade stage 1 non-seminoma limited to the testes, radical orchiectomy with retroperitoneal lymph node dissection. Low-grade seminoma, radical orchiectomy, may need radiation or para-aortic lymph nodes or platinum-based chemo. High-grade seminoma, debulking chemo followed by orchiectomy and radiation. Prognosis: generally excellent. 5-year survival is over 95%. Next will be hydrocele, which is a serous fluid collection within the layers of the tunica vaginalis of the scrotum. Most common cause of painless scrotal swelling. Idiopathic is the most common. A reactive hydrocele can occur with inflammatory conditions like epididymitis, orchitis, or testicular tumor. So there's 2 types of hydroceles: communicating, which is a peritoneal and abdominal fluid enters the scrotum via a patent processus vaginalis that failed to close previously. Also a non-communicating hydrocele, which is derived from fluid from the mesothelial lining of the tunica vaginalis, no connection to the peritoneum. Clinical manifestations are painless scrotal swelling, may increase throughout the day, and may complain of dull ache or heavy sensation with increasing size. On physical exam: translucency, seen on transillumination. Fluid located anterior and lateral to the testes. Swelling is worse with Valsalva if it's a communicating one, because if you're increasing the intra-abdominal pressure, you're pushing the fluid down further into the scrotum. For diagnosis, testicular ultrasound is the initial test of choice, and it's used to rule out testicular tumor and other masses. For treatment of hydrocele, usually no treatment is needed. Watchful waiting often resolves within the first 12 months of life in infants. In adults, they're often self-limited as well. Surgical excision may be needed if it persists beyond 1 year of age in infants. Older patients with communicating hydroceles, electively, to reduce the risk of hernia or hydroceles associated with complications. Next will be spermatocele, which is also called an epididymal cyst. Epididymal cyst is scrotal mass that contains sperm. Spermatocele if over 2 centimeters. So it has sperm in it, and it's located posterior and superior to it. Clinical manifestations: painless cystic testicular mass. Physical exam: a round, soft mass in the head of the epididymis, superior and posterior, and separate from the testicle. Freely movable mass above the testicle that transilluminates. A cyst filled with sperm and fluid. Diagnosis by scrotal ultrasound, and no treatment is usually needed unless the mass is bothersome. Surgical excision for chronic pain, although rarely needed. Varicocele. A varicocele is a cystic testicular mass of varicose veins. It's the pampiniform venous plexus and internal spermatic vein. Most common surgically correctable cause of male infertility, seen in about 30% of infertile men because of the increased temperature from increased venous blood flow that inhibits spermatogenesis. Most are left-sided, increased left renal vein pressure transmitted to the left gonadal vein, and clinical manifestations. So remember the left-sided vein as it drains into the renal vein as opposed to right into the aorta. That's the left side. Clinical manifestations, asymptomatic varicoceles are found in 10% of the population and also may cause testicular atrophy. Usually painless, but may cause a dull ache or heavy sensation. On physical exam, a soft scrotal mass or a classic bag of worms superior to the testicle. Dilation worsens when patient is upright or with Valsalva, as the blood flows with gravity. Less apparent when the patient is supine or with testicle elevation. For diagnosis, it's clinical, and for ultrasound, that's the initial test of choice, and you'll see dilation of the pampiniform plexus, which is over 2 millimeters. For management, you can observe in most cases, and surgery in some cases for pain, infertility, or delayed testicular growth, such as spermatic vein ligation, varicocelectomy, or percutaneous venous embolization. Varicocele associations, a right-sided varicocele may be due to a retroperitoneal or abdominal malignancy. Unilateral right-sided varicoceles are otherwise uncommon. And a sudden onset of a left-sided varicocele in an older man may be possible due to renal cell carcinoma. So the left side is more common, but if it's sudden and older, you want to think renal cell carcinoma, as remember that gonadal vein drains into the renal vein as opposed to the aorta. So a bulging kidney can press up against that and lead to obstruction. Next will be urethral strictures, narrowing of the urethral lumen. Etiologies are infection, STI or UTI, trauma or instrumentation of the urethra, or idiopathic. Clinical manifestations, chronic obstructive voiding symptoms, leading to a weak urinary stream and incomplete bladder emptying, recurrent UTIs, urinary spraying, or dysuria. For diagnosis, patients with symptoms and poor bladder emptying, increased post-void residual, should undergo cystourethropy, retrograde urethrogram, voiding cystourethrogram, or ultrasound urethropy. For management, endoscopic treatment such as dilation, cold knife incision, incision with electrocautery or laser, or intermittent catheter dilation, or surgical reconstruction. So remember also that these strictures, if you're putting a catheter in, you may need the coude catheter, which has the bent tip to get past the prostate and stricture. And also complications are urinary fistulas, and prophylactic antibiotics are recommended prior to cystourethropy and surgery. Next will be bladder carcinoma. This is the most common malignancy of the GU system. Urothelial or transition cell carcinoma is the most common type, very important. That's urothelial or transition cell carcinoma is the most common type. Squamous cell adenocarcinoma, sarcoma, and small cell are also possible. For risk factors, smoking is the most common, over 60%. Occupational exposure to dyes, leather, and rubber. Age over 40, Caucasian, male sex, and also schistosomiasis. Medications, cyclophosphamide and pioglitazone, importantly. Long-term indwelling catheter use and infected bladder stones are associated with squamous cell carcinoma. Clinical manifestations, painless gross hematuria is most common. It may be microscopic, usually intermittent and throughout micturition. Irritative symptoms like dysuria, which is the second most common, urgency and frequency. For diagnosis, urinalysis with microscopy and cultures to rule out benign causes, UTI, pyelonephritis. Imaging of the GU tract, CT urography is preferred, or IV pyelogram. Cystoscopy with biopsy is the gold standard, can be both diagnostic and curative. Urine cytology is adjunctive. For management of bladder carcinoma, Localized or superficial, you can do transurethral resection of the bladder tumor, electrocautery, and follow up every 3 months if it's localized again or superficial. If it's invasive, with advanced or muscular invasion, you may need to do a radical cystectomy, chemotherapy, radiation therapy. If it's recurrent, you can do, interestingly, intravesicular BCG, the Bacillus calmette-guerin vaccine, if electrocautery is unsuccessful. That's the intravesicular BCG vaccine. Immune reaction stimulates cross-reaction with tumor antigens. Do not use BCG if immunocompromised or if gross hematuria is persistent. Next will be paraphimosis. Paraphimosis is a retracted foreskin that cannot be returned to the normal position. The foreskin cannot be pulled forward. A urologic emergency. Pathophys is a retracted foreskin becomes trapped behind the corona of the glands and forms a tight band, constricting penile tissues, which can lead to gangrene. Etiologies: forceful retraction of the phimotic foreskin. Infants and young boys, usually physiologic or iatrogenic. Adolescents and adults can occur after Pyelonephritis or penile inflammation, such as through diabetes mellitus or after sexual activity. Clinical manifestations: severe penile pain or swelling. Physical exam: enlarged, painful glands with constricting bands of foreskin behind the glands. Management: manual reduction. Restore the original position of the foreskin. Reduce edema with cool compresses or pressure dressings that gently pressure to restore the foreskin to its normal position. Pharmacologic: granulated sugar, injection of hyaluronidase. Definitive management: incision, such as a dorsal slit or circumcision. Phimosis, differently from paraphimosis, is inability to retract the foreskin over the glands. Phimosis is not a urologic emergency, unlike paraphimosis. Pathophysiology is distal scarring of the foreskin, such as after trauma, infection, or inflammation. And management is proper hygiene, stretching exercises, which may spontaneously resolve it, or 4 to 8 weeks of topical corticosteroid can increase foreskin retractability, may be an adjunct to stretching, and circumcision is the definitive management. Next will be BPH, benign prostatic hyperplasia. Prostate hyperplasia, periurethral or transitional zone, leading to bladder outlet obstruction. Common in older men, discrete nodules in the periurethral zone. Hyperplasia is part of the normal aging process and is hormonally dependent on increased dihydrotestosterone production, we'll get into the mechanism of the 5-alpha reductases as they work to inhibit this dihydrotestosterone production. Clinical manifestations for BPH: irritative symptoms like FUD, frequency, urgency, dysuria, and nocturia. Obstructive symptoms: hesitancy or weak or intermittent stream force, incomplete emptying, and terminal dribbling. Sympathomimetics like pseudoephedrine and anticholinergics may worsen the symptoms, as they all constrict the urethra more. For diagnosis: DRE, digital rectal exam, you'll have a uniformly enlarged, firm, non-tender, rubbery prostate. A PSA could be gotten, a prostate-specific antigen, which is correlated with the risk of symptom progression. So a normal PSA is under 4. Urinalysis to look for hematuria or other causes of symptoms. And urine cytology, if increased risk of bladder cancer, history of tobacco use, irritative bladder symptoms, or hematuria. So remember, for bladder cancer, tobacco use and hematuria, big causes. For management of BPH, observation with mild symptoms, monitored annually, and you can use alpha blockers, which is the best initial therapy to rapidly relieve symptoms, but they do not change the prostate size. Tamsulosin is the big one, and also terazosin or doxazosin. Hypotension is the most common adverse effect, especially first dose hypotension. So remember, those alpha blockers, they're the best initial therapy to rapidly relieve symptoms, but they do not change the course of the disease, as opposed to 5-alpha reductase inhibitors, which actually reduce the size of the prostate over time, over 6 to 12 months. That's finasteride and dutasteride. So they inhibit a step in steroid synthesis, and affects the size over time of the prostate. Also, there could be surgical management done, which is an option if persistent, progressive, or refractory despite combination therapy for 1 to 2 years, actually. TURP procedure, transurethral resection of the prostate, removes excess prostate tissue, relieving the obstruction. May cause sexual dysfunction, urinary incontinence. Also, laser prostatectomy, the Urolift is called. So to go over those medications in more depth, the alpha-1 blockers are tamsulosin, is the most uroselective, and also alfuzosin, doxazosin, and terazosin. Indications for the alpha-1 blockers are providing rapid relief of symptoms with no effect on the clinical course of BPH again. Mechanism of action, smooth muscle relaxation of the prostate and bladder neck, leading to decreased urethral resistance, obstructive relief, and increased urinary outflow. Alpha-1 agonist activation in the prostate and urethra normally causes bladder neck contraction and decreased flow. So it's going to block that contraction. Adverse effects, non-selective, such as dizziness or orthostatic hypotension due to alpha-1 antagonism, and retrograde ejaculation. 5 alpha reductase inhibitors, finasteride and dutasteride. The mechanism is an androgen inhibitor, inhibits the conversion of testosterone to dihydrotestosterone, suppressing prostate growth, reducing bladder outlet obstruction. Doesn't provide immediate relief but has a positive effect on the clinical course of BPH by reducing the size and the decreased need for surgery, which is unlike alpha blockers. Reduction in size takes 6 to 12 months. Indications, BPH, and also male pattern baldness. Adverse effects, sexual or ejaculation dysfunction, decreased libido, breast tenderness, and enlargement. As we're decreasing testosterone, so you're going to get some anti-androgenic effects. Next will be prostate cancer itself. This is a slow-growing tumor. After skin cancer, prostate cancer is the most common cancer in men in the U.S. Prostate cancer is the second most common cause of cancer deaths in men behind lung cancer. However, most men die with prostate cancer rather than from it. Adenocarcinoma is the most common type, as 95%. Risk factors of prostate cancer, increasing age over 40, which is the strongest risk factor, importantly. So increasing age, strongest risk factor, also genetics. African Americans have a higher incidence as well, and also a diet high in animal fat and decreased vegetables is a risk factor. Clinical manifestations, most are asymptomatic and are diagnosed either via an abnormal DRE or via workup after abnormal PSA or until invasion of the bladder, urethral obstruction, or bony involvement. Urethral obstruction, urinary frequency, urgency, retention, or decreased urinary stream. Back or bone pain is an increased incidence of mets to the bone or weight loss. For diagnosis, a DRE should be done, which you'll find a hard, indurated, nodular, enlarged, and asymmetric prostate. Again, hard, indurated, nodular, enlarged, and asymmetric prostate. PSA can be seen in other prostate disorders, but abnormal values may be based on a general number, about over 4, or based on an age-related normal value. The TURP procedure, or transurethral resection of the prostate, or transrectal ultrasound-guided needle biopsy, can be done for the most accurate test. Indications include a PSA over 4 in a patient with a high suspicion, such as a palpable mass, or if over 10, order a bone scan to rule out mets. The Gleason grading system determines aggressiveness or malignant potential of prostate cancer. A higher grade suggests more benefit from the surgical removal. That's the Gleason grading system for prostate cancer. So the Gleason grading system shows the histology that's more likely to become cancerous. For management of prostate cancer, appropriate management is controversial because in many cases they're latent and do not progress while others do metastasize. Local disease options include observation and active surveillance, very low risk, clinically localized, or life expectancy under 10 years versus definitive treatment, external beam radiation therapy, brachytherapy, or radial prostatectomy. Adverse effects of prostatectomy include incontinence and erectile dysfunction, more likely compared to radiation. Advanced disease, external beam radiation therapy, hormonal therapy, androgen deprivation, orchiectomy plus flutamide plus GnRH agonists. Abiraterone is a 17-hydroxylase inhibitor that decreases progression of metastatic prostate cancer, and also chemotherapy if hormonal therapy is ineffective for advanced disease. Next will be hematuria. Hematuria etiologies causes vary with age of hematuria, with the most common onset in under 40 years being inflammation or infection of the bladder or prostate or nephrolithiasis. In over 40 years old, a kidney or UTI or urinary tract malignancy or BPH may be the cause. For the upper GU tract, nephrolithiasis, kidney disease, renal cell carcinoma, trauma, diabetes, sickle cell trait, or disease. For the lower GU tract, BPH is the most common cause of microscopic hematuria in men, urothelial cancer in the absence of infection, sexual or physical activity, and illness. Pseudo-hematuria, rhabdomyolysis due to the myoglobin, beets, rhubarb, myoglobinuria contains heme, and hemoglobinuria. Medications like ibuprofen, phenazopyridine, rifampin, importantly, and cyclophosphamide, hemorrhagic cystitis from cyclophosphamide. Timing of the hematuria. If it's terminal, it's bladder irritation, such as a stone or infection or prostate. If it's throughout micturition, it's a bladder, ureter, or kidneys. Or if it's initial, it's urethral in origin. For diagnosis of hematuria, urinalysis is usually the initial test of choice to rule out benign causes like UTI or pyelo. Urine culture performed if urinalysis suggestive of UTI. Repeat urinalysis after 6 weeks of treatment for resolution of hematuria. And a CT urography or cystoscopy recommended if urinalysis is negative for infection, plus gross hematuria with visible clots. A workup of choice after non-infectious urinalysis in patients over 40 years old. You want to do that CT urography or cystoscopy, especially if initial imaging is negative. Nephrology referral if gross hematuria plus no visible clots. The nephrologist can determine which tests need to be done. You can do an IV pyelogram. Ultrasound can also be used to evaluate kidney to rule out kidney stones. Ultrasound may be the initial test of choice after urinalysis in pregnant patients or patients unable to receive contrast. And you can also do cytology to rule out bladder cancer. Next, we'll go into nephrolithiasis. So there's many different types. First, calcium oxalate is the most common, and also calcium phosphate. Uric acid are 5 to 8%. Increased uric acid is due to high protein foods, gout, chemotherapy, such as tumor lysis syndrome. Tumor lysis syndrome for uric acid. Acidic urine promotes uric acid stone formation as well. Struvite, composed of magnesium, ammonium, and phosphate. MAP, struvite is MAP, magnesium, ammonium, and phosphate, may form staghorn calculi in the renal pelvis due to urea splitting organisms, especially Proteus, Klebsiella, Pseudomonas, Serratia, and Enterobacter. But don't forget Proteus for struvite, or a complication of a UTI with these organisms. Cysteine is rare, 1 to 3%. This is a congenital defect in resorption of the amino acid cysteine. Clinical manifestations are renal colic, sudden, constant upper lateral back pain, or flank pain over the CVA, radiating to the groin or anteriorly, the testicles in men or the labia in women. May be difficult to find a comfortable position, so they're moving all around to find a position, as opposed to an appendectomy, they aren't moving at all. Nausea, vomiting frequency, urgency, and especially hematuria. Pain varies with stone location. Could be flank pain, CVA tenderness with proximal ureteral stones, mid-abdominal pain and with mid-ureteral, and groin pain with distal ureteral stones. Physical exam, usually afebrile and especially CVA tenderness. For diagnosis, urinalysis, you'll have microscopic or gross hematuria in 85%. Nitrates if infectious, and also an acidic urine, which is a pH under 5, is more indicative of uric acid and cysteine stones. An alkalotic urine of over 7.2 is associated with struvite stones. importantly. Non-contrast CT of the abdomen and pelvis is the imaging test of choice. So not ultrasound, but rather CT of the abdomen and pelvis. Renal ultrasound detects stones or complications like hydronephrosis. It's used in children or if a CT is contraindicated, such as in pregnancy. A KUB radiograph can be used too, but it only detects calcium and struvite stones that are radio-opaque, which are visible in radiographs. It may miss smaller stones even if they are radiopaque too, and it cannot see the radiolucent ones, obviously. Intravenous pyelography, not used as often, less sensitive and specific than CT. So for nephrolithiasis, number one thing, you want to do a CT of the abdomen and pelvis. You can also do ultrasound in specific cases and know about the radiographic findings and also urinalysis findings of the acidic stones, which are uric acid and cysteine, or alkalotic stones, which are struvite. So management of kidney stones, stones under 5 millimeters in diameter, 80% chance of spontaneous passage. IV fluids and analgesics, antiemetics if nauseous. Tamsulosin, which is an alpha blocker, may facilitate passage. Stones at the ureteral vesicular junction, the narrowest point of the urinary tract, the UVJ, and ureteral pelvic junction may make passage of stones very difficult. UVJ. Stones 5 to 10 millimeters in diameter have a 20% chance of spontaneous passage. If uric acid stones are present, alkalinization of the urine to a pH of over 6.5 helps to dissolve uric acid stones. Extracorporeal shockwave lithotripsy may be used to break up larger stones that are less likely to pass spontaneously, may need multiple treatments to reduce the size of the stones. Uretoscopy, with or without stent, may be used to provide immediate relief to an obstructed or at-risk kidney. Percutaneous nephrolithotomy is the most invasive and it's used for large stones over 10 millimeters, struvite stones, staghorn, or if other less invasive modalities fail. Incision is made in the back and the stone is removed via a tube. So to go into each of the stones and nephrolithiasis prevention. So calcium stones, calcium oxalate is the most common cause. Calcium phosphate is also possible. Calcium stones make up about 80% of all stones. Risk factors are decreased fluid intake as the most common, also an alkaline urinary pH, higher urinary calcium, higher urinary oxalate, lower urine citrate, males, medications. So remember citrate, when you give blood transfusion, citrate in it can bind to the calcium. So it makes sense that a lower urine citrate would lead to more calcium being there and more chance for stones to form. So males, medications, loop diuretics, acetazolamide, antacids, chemotherapeutic drugs, indinavir and topiramate as well. Also high animal proteins and hypercalcemia, polycystic kidney disease, and increased vitamin C intake in men. Prevention increases fluid intake, thiazide diuretics, citrate. So this is for prevention now. So for prevention of calcium oxalate and phosphate stones is increased fluid intake, thiazide diuretics, citrate, low sodium diet, decreased animal protein. So thiazide diuretics decrease the calcium in the urine itself. So for loop diuretics, they increase the excretion of calcium as it's a treatment for hypercalcemia. But that also forces more calcium into the nephrons, so higher chance for it to form a stone. But for thiazide, remembering they inhibit the reabsorption of GLUC, so glucose, lipids, uric acid, and calcium, so less calcium is going into the urine itself. Next will be uric acid stones. These are 5 to 8%. Increased uric acid due to high protein foods, gout, chemotherapy due to tumor lysis syndrome. Acidic urine also promotes uric acid stone formation. Again, these are not usually visualized on KUB, radiograph. They're radiolucent. Prevention, increased fluids, allopurinol or potassium citrate, also urinary alkalinization, adequate hydration prior to chemo. Struvite stones composed of MAP, magnesium ammonium phosphate, may form staghorn calculi in the renal pelvis due to urea splitting organisms like Proteus, importantly, Klebsiella, Pseudomonas, Serratia, and Enterobacter, or can be due to a complication of a UTI with these organisms. For prevention, you want to control the source of the infection. Lastly, for cystine stones, these are rare, 1 to 3%. It's a congenital defect in reabsorption of the amino acid cysteine from the urine, not usually visualized on KUB. For prevention, a dietary modification, low sodium, and urine alkalinization, such as with acetazolamide, chelating agents in refractory cases as well. Next will be penile cancer. It's rare in the US, Europe, or other industrialized countries. The mean age of diagnosis is 60. Most common is squamous cell carcinoma. Remember, adenoma is the most common for prostate cancer. Squamous cell cancer is the most common for penile, most commonly associated with HPV type 16 and 18. Smoking, lack of circumcision as well, and HIV. Also no Bowen's disease, which is leukoplakia of the shaft of the penis or scrotum. Peak incidence is over 50 years old and associated with HPV type 16. A minority of cases progress to squamous cell carcinoma. Clinical manifestations: a mass, a palpable lesion or ulceration of the penis, most commonly on the glands, coronal sulcus or prepuce. May have inguinal lymphadenopathy. Rare presentations include rash, bleeding, or balanitis. Diagnosis is by biopsy. May seed into the inguinal lymph nodes, followed by pelvic or retroperitoneal lymph nodes. Management in early disease is limited excision, and later disease is amputation with therapeutic lymph node dissection. Erectile dysfunction, consistent or recurrent inability to generate or maintain an erection. Etiologies: vascular is the most common, with atherosclerosis and diabetes. Neurologic, psychogenic, prolactinoma, trauma, or surgery. Medications like beta blockers, thiazide diuretics, spironolactone, calcium channel blockers, SSRIs, and TCAs. An abrupt onset is most likely psychological, whereas gradual worsening indicates a systemic disease. Diagnosis: history and physical, testosterone level, other hormone testing. Nocturnal penile tumescence used to evaluate for sleep erections. Duplex ultrasound to evaluate penile blood flow. And for management, phosphodiesterase 5 inhibitors, PDE5s, sildenafil, tadalafil, varenicline. Indications are first-line therapy. The mechanism is a phosphodiesterase 5 inhibition, increases the cyclic GMP, and potentiates nitric oxide. Nitric oxide-mediated smooth muscle relaxation, leading to the ability to generate and maintain the erection. Adverse effects: headache, flushing, rhinitis, visual disturbances, and hearing loss. And it's very important to note the contraindication is not to be used with nitrates or patients with cardiovascular disease, as it may cause severe hypotension as it's synergistic with nitrous oxide. Second-line therapy: intracavernosal injection with prostaglandin E1, alprostadil, or papaverine, or combination of papaverine plus phentolamine, which causes vasodilation, increasing arterial inflow. Also vacuum pump. Third line: prosthesis or corrective revascularization, and testosterone, hormonal replacement if testosterone is low due to an androgen deficiency. Next will be hypospadias. This is a congenital anomaly of the male urethra that results in an abnormal ventral placement of the urethral opening, penile curvature, or abnormal foreskin development. The urethral opening will be within the glands, shaft, the scrotum, or perineum. Second most common congenital in males after cryptorchidism. Pathophysiology is failure of the urogenital folds to fuse during development, abnormal development of the urethral fold and the ventral foreskin of the penis. Proximal hypospadias is usually associated with additional GU malformation. Clinical manifestations: increased risk for UTIs, deflection of the urinary stream as well. Physical exam: the ventral placement of the urethra, abnormal foreskin with incomplete closure around the glands, a dorsal hooded prepuce, and also an abnormal curvature, chordae. Management: these patients should not be circumcised in the neonatal period because the foreskin may be used to repair the defect, importantly, with hypospadias. Elective surgical reconstruction or surgical correction, which is an arthroplasty, may include penile straightening, hypospadias repair usually performed in healthy full-term infants, most commonly between 6 months and 1 year of age. Epispadias, on the other hand, is a congenital anomaly of the male urethra that results in abnormal dorsal displacement of the urethral opening, often associated with bladder exstrophy, which is protrusion of the bladder wall through a defect in the abdominal wall. So exstrophy and epispadias. Epispadias, failure of the midline penile fusion, bladder exstrophy, in utero rupture of an overdeveloped cloacal membrane, leading to herniation of the lower abdominal contents. Clinical manifestations: opening of the urethral meatus on the dorsal top surface of the penis, dorsal upward curvature, as well as absent dorsal foreskin. Diagnosis is a bladder exstrophy, often made by prenatal ultrasound, and surgical correction. Next will be urethral injuries. Urethral injuries are more common in men. Blunt trauma is the most common, 80%. Anterior urethral injuries, like a straddle type falls or direct blows. Posterior urethral injury, like pelvic fractures or MVAs. For clinical manifestations, gross hematuria, difficulty urinating, urinary retention, or lower abdominal pain. On physical exam of urethral injuries, there'll be blood at the urethral meatus, very important, swelling or ecchymosis of the scrotum or perineum, and a high riding prostate. So, physical exam for indicative of urethral injury: high riding prostate, blood at the meatus, swelling or ecchymosis. For diagnosis, you want to assess for injuries and fractures. Retrograde urethrogram is the diagnostic test of choice, importantly. Must be done prior to transurethral catheterization. Urinalysis may show hematuria. Hallmark triad of urethral injury is blood at the urethral meatus, inability to void, and a distended bladder. For management, non-operative catheter placement and monitor for healing. Surgical repair is indicated in severe injuries, may involve temporary suprapubic catheter placement prior to repair. So next we'll be going over some of the tumor markers and their main associations. So first, alpha-fetoprotein, importantly, is hepatocellular carcinoma. Also, non-semitomatous germ cell testicular cancer. And also know it's decreased in Down syndrome. So AFP is down in Down syndrome, trisomy 21. Beta HCG, again, non-seminomatous germ cell testicular cancer. Choriocarcinomas, teratomas, and also trophoblastic tumors, like a hydatidiform molar pregnancy. CA125, ovarian cancer. CA19-9, pancreatic cancer, also GI, colorectal, esophageal, hepatocellular. Calcitonin, medullary thyroid cancer. CEA, colorectal cancer. Medullary thyroid, pancreatic, gastric, lung, and breast is also. And prostate-specific antigen, PSA, is prostate cancer. Can also be slightly elevated in BPH and prostatitis. So next will be priapism. This is a prolonged, painful erection without sexual stimulation. Ischemic, low flow state, which will be a decreased venous outflow, which may lead to a compartment syndrome, increasing acidosis and hypoxia in the cavernous tissues. Becomes painful and rigid, and it's the most common type, the ischemic or low flow. Or it could be also a non-ischemic high flow, which is increased arterial inflow due to a fistula between the cavernosal artery and the corpus cavernosum, commonly related to perineal or penile trauma. This is less painful and not fully rigid compared to ischemic. So ischemic most common, but can also be non-ischemic high flow. Etiology is most commonly idiopathic, but also no sickle cell disease is important. Injection of an erectile agent for erectile dysfunction, also drugs like cocaine, marijuana, alcohol. Trauma in high flow states may cause rupture of the cavernosal artery. And medications like PDE5s, also trazodone, don't forget, antipsychotics, anticonvulsants, and beta blockers. neurologic, head trauma, meningitis, subarachnoid hemorrhage, and post-op. So don't forget sickle cell and especially trazodone. Diagnosis, primarily based on history and physical. Blood gases may be performed in erections over 4 hours. If you do a cavernosal blood gas, this will show a high flow result similar to ABG and normal glucose. Low flow shows hypoglycemia, hypoxemia, hypercarbia, and acidemia. Doppler ultrasound will show a normal or high flow in non-ischemic, minimal or absent blood flow in ischemic. So management of ischemic or low flow states. This is, you want to do phenylephrine as the first line medication, which is an intracavernosal injection of phenylephrine. The mechanism is alpha agonists cause constriction of the cavernosus smooth muscle, which increases venous outflow. Contraindications are cardiac or cerebrovascular history. You can also do needle aspiration of the corpus cavernosum and irrigation to remove blood, especially for over 4 hours duration, with or without phenylephrine. So you can do a combo therapy of needle aspiration and phenylephrine. And a combination therapy is more effective than corporeal aspiration alone. You can also do ice packs. And so this is all for ischemic or low flow state, which is the decreased venous outflow. So you want to constrict the vessels to push the blood out. Also, terbutaline, orally or sub-Q, constricts the cavernosal artery, reducing arterial inflow. May be used if under 4 hours, but it's not as effective. And also, shunt surgery may be performed if non-responsive to medical or aspiration therapy. For arterial or non-ischemic high flow states, you can observe them as they mostly resolve within hours to days. In refractory, non-permanent arterial embolization or surgical ligation may be used if refractory. And lastly, for the GU section, enuresis. This is distinct episodes of urinary incontinence, bedwetting, while sleeping in children of 5 years of age or older. Evaluation, a complete history, physical, voiding diary, and urinalysis. Monosymptomatic enuresis in the absence of a low urinary tract infection symptoms or without bladder dysfunction. High rates of spontaneous resolution. It's a primary enuresis if they're absence of any period of nighttime dryness, which is the most common type. They also may have a family history. For secondary enuresis, this is enuresis after a dry period of at least 6 months, usually due to an unusual stressful event, like birth of a sibling, parental divorce. Management, behavioral is the first line therapy, motivational therapy in 5 to 7 years, education and reassurance, use of washable products and room deodorizers, also bladder training. You can also do an enuresis alarm, which is the most effective long-term therapy, usually used in children if they fail to respond to behavioral therapy. So this is often attempted before medical therapy. A sensor is placed on a bed pad or in the undergarments and goes off when it's wet, usually continued there until a minimum of 2 weeks of consecutive dry nights. Also DDAVP, desmopressin, used in nocturnal polyuria with normal bladder function capacity, better for short-term use. Mechanism is synthetic ADH, which reduces urination, causes hyponatremia, so patients may use liberal amounts of salt to reduce the incidence of this. Imipramine, a TCA, can be used in refractory cases of enuresis. Stimulates ADH secretion, detrusor muscle relaxation, and decreases time spent in REM sleep, however. So remember actually imipramine for incontinence as well. So that concludes the GU section of Pance Prep Pearls.